Yes, please.
Okay, so should I start?
Let Hambir speak first for
Sir,
and then.
Okay.
just a minute, sir.
Thank you.
Good
Hambir, you
evening,
can start.
everyone. We are going. Okay, sir. Thank you. Good evening, everyone. We are going to start the penultimate module of the clinical oncology course. Today, our respected faculties are going to enlighten us about the basic knowledge and recent management of lung carcinoma. We request all the participants to put up their microphone in mute mode. If anyone having any doubt, please raise your hand or type your question in the question answer box. Jivak sir, is recording started?
Yes.
Okay. So our first speaker, our first esteemed speaker, Dr. Somodip Panda, consultant radiation oncologist from Sarojgatto Cancer Research Center. He will enlighten us about the pathology, biology, and risk factor of lung cancer. Sir, please start.
Thank you, Hambir, for the nice introduction.
Most welcome, sir.
And good evening, everybody. And my topic, as we all know, is lung cancer, and the content of this topic are etiology, pathological classification, driver mutations and molecular targets in non-small cell lung cancer, the symptomatology and workup. And so why lung cancer is so important? Because lung cancer has very high incidence, and as well as it is the most common cause of cancer related death. As we can see from the Globocan 2020, in worldwide, in male, it is the most common cause of cancer, and also in female, it is not lagging behind. It is around the third most common cause of cancer. In India, it's also quite prevalent. In male, it is the second most common cancer, just after the lip and oral cavity cancer. And in all ages, that means both sexes, inclusive of the male and female, it is the fourth most common cause of cancer. And in our day-to-day practice in OPD, in indoor, we encounter lung cancer cases in various stages, mostly in the locally advanced or metastatic. So what are the etiology? That means what are the positive agents for the lung cancer? As we all know, that is a very basic cause of lung cancer is smoking. So smoking can be active smoking, or it can be a secondhand smoke or the passive smoking, and occupational exposures, asbestos, and currently the increase in the pollution, and in USA particularly the exposure to the radon, the radioactive element, and in few cases the genetic predisposition, and also in some patients with long-standing COPD. So smoking, it's the most common cause. Around 80 to 90% of the lung cancer cases are due to the smoking, and mainly the reason behind the carcinogenesis is that the cigarette smoke, it contains lots of carcinogens, almost more than 70 carcinogens are there, like nitrosamines, the polycyclic aromatic hydrocarbons, and acetaldehydes, as well as the nicotine, which is a very strong addictive substance. So mostly this is the smoking is due to the field cancerization. It not only causes the lung cancer, but it also leads to the cancer of the oral cavity, the esophagus. That means the entire aerodigestive tract is, when it's exposed to the smoke and its carcinogens, it may lead to the preneoplastic lesion and ultimately leading to the invasive carcinoma. And the pathogenesis, that means how the carcinogens they lead to the cancer. The basic thing is that the cigarette smoking, the carcinogens, they gets activated by the cytochrome based enzymes, and after their metabolic activation, they will lead to DNA adducts. Sometimes they will be repaired, leading to again normal DNA. Sometimes the cells will be apoptotic if that damage cannot be repaired. But this persistent miscoding will lead to the mutation in the tumor suppressor gene, like P53, P16, PRB, like that. And also the carcinogen, they lead to methylation of the promoter region, leading to decreased synthesis of the tumor suppressor gene, leading to enhanced carcinogenicity. And also these carcinogens, they will lead to the binding to the receptors, leading to the activation of the oncogenes. And ultimately, they will lead to the uncontrolled cellular proliferation, decreased apoptosis, and increased angiogenesis. Ultimately, they will lead to the lung cancer and other digestive tract cancers like oral cavity, esophageal cancer, etc., etc. Now, coming to the histological classification of lung cancer, this is a very important slide for the trainees. That is, there is a broad classification of the lung cancer into the non-small cell lung cancer and small cell lung cancer. But the non-small cell lung cancer comprises about 80% of the cancers, and small cell around 15 to 20%. The non-small cell lung cancer, again, it is subdivided into three major histological types, like, as we all know, the adenocarcinoma, which is again the most common type of non-small cell lung cancer, around 40%. And also it is the most common type of lung cancer in the non-smokers. But currently, the incidence of adenocarcinoma is increasing even in the smokers. Obviously, we see it in the smokers due to the filtered cigarettes. And the types of the adenocarcinoma are lipidic variant, there is papillary, micropapillary, there is fetal, colloid, mucinous, and enteric type. And mostly they are peripherally located, these carcinomas. And next, the squamous cell carcinoma, it is mostly associated with smoking, and it is around 25% of the non-small cell lung cancers. And it is mostly centrally located, and with there may be central necrosis and cavitation. And there is a large cell carcinoma, it is around 10%, it is mostly peripheral. And behavior wise, it is a very aggressive tumor, and it can be called as a small cell cancer counterpart of the non-small cell type. That means behavior wise, it's a very aggressive tumor. And then the small cell lung cancer, it is around 15%. It is a centrally located tumor. There is associated massive lymphadenopathy, paraneoplastic syndromes are associated with it, and other uncommon types are there, and 4 to 5% cases carcinoids, like the typical and atypical carcinoids. So in the biopsy specimen, we'll look for the histological type like adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and sometimes it can be adenosquamous as well. Sometimes it may be polydifferentiated as well. And so ultimately, there is a very important role of the immunohistochemistry. So immunohistochemistry markers, which is specific for the adenocarcinoma, the TTF1, that is the thyroid transcription factor 1, and NAPSINA, and which are mostly positive in cases of the adenocarcinoma, and they will be negative for the P63 and P40, whereas in case of squamous cell carcinoma, they'll be mostly positive for the P63 and P40. The small cell lung carcinoma, there is a distinct group of molecular markers like synaptophysin, chromogranin, CD56. So these are the commonly commonly expressed markers in case of small cell lung cancer. And based on that, the histological examination and IHC, we can establish the diagnosis. Next important issue is the driver mutations in the lung adenocarcinoma. The non-small cell carcinoma, there is the adenocarcinoma, there is a group of driver mutations that we can observe, like mostly the EGFR sensitizing mutations and EGFR other. EGFR other means these are also EGFR mutations which are not sensitizing. That means for them we don't have any EGFR tyrosine kinase inhibitors. So EGFR sensitizing mutations are around 15%. And another important predictive marker is the KRAS. KRAS, as we can see, it is a very common mutation. Is around 25% cases there may be KRAS mutation. but unfortunately there is no targeted agent against the KRAS mutation. And mostly the KRAS and EGFR, these mutations are mutually exclusive, and KRAS mutation obviously denotes very poor prognosis. And other mutations which are which we can observe are the EML4 ALK rearrangements, the ROS1 rearrangements. BRAF mutation is there, some targeted agents are there, but it is not widely available. So mostly regarding the driver mutations, you have to remember three types of mutation. One is the EGFR sensitizing mutation, another is the ALK rearrangement, another is the ROS1 rearrangement. So this is the EGFR pathway, and in EGFR mutation, commonly the tyrosine kinase domain, we have the targeted agents against this tyrosine kinase domain. And there are various types of the EGFR tyrosine kinase inhibitor, the EGFR tyrosine kinase sensitive mutations. So the common mutations which we should always look for are the exon 19 deletion and exon 21 L858R mutation, and also the exon 20 is the T790M mutation. Another is the deletion of the exon 18. There are other mutations as we can see, but these are, as I have already told, these are not sensitizing. And commonly against the exon 19 deletion and exon 21 L858R and exon 18 deletion, we have tyrosine kinase inhibitors like gefitinib, erlotinib, and afatinib. Against T790M, there is osimertinib, gefitinib, erlotinib. These tyrosine kinase inhibitors are not very effective against this kind of mutation. And mostly the patients who are on this tyrosine kinase inhibitor like erlotinib and gefitinib for the Del19 or the L858 or mutations, after around 15 months or 18 months, they are going to exhibit some form of resistance. And then mostly the reason of that resistance is development of that T790M mutation in the exon 20, which are basically non-responsive to this tyrosine kinase inhibitors. And this is the image showing the EML4 and the ALK, that is the anaplastic lymphoma kinase rearrangement. And these are the basically drugs, the tyrosine kinase inhibitors that we have against these mutations. Like for EGFR mutation, as I have already mentioned, there will be erlotinib, gefitinib, afatinib, osimertinib. And for the ALK rearrangements, there will be crizotinib, ceritinib, these are the drugs. And for the ROS1 rearrangement, also crizotinib is very important. Next, the signs and symptoms of the lung cancer. The lung cancer signs and symptoms, mostly they are due to the intrathoracic spread of the disease, and also the regional spread of the disease and the distal metastatic spread. And some symptoms they cannot be explained by the presence of the tumor. They are mostly due to the paraneoplastic syndrome, which are basically due to the synthesis of the humoral factors from the tumor or due to the immune response against the tumors. So the common symptom due to the lung cancer, which are mostly due to the intrathoracic spread of the tumor, are persistent cough, hemoptysis, and chest pain, and weight loss and unexplained weight loss, obviously. And other symptoms will be frequent chest infections and hoarseness of the voice. So these are the symptoms. And regarding the intrathoracic spread, two symptoms are very important. One is the symptoms due to the superior vena cava obstruction, and another one is the Pancoast syndrome. Now, superior vena cava obstruction, this is a CT scan showing that the entire SVC is compressed. So here, basically, to the mediastinal invasion of the tumor or the presence of the lymphadenopathy, the superior vena cava is compressed, leading to the dilatation of the venous system, the subclavian vein, the jugular vein, leading to the puffiness of the face, leading to neck swelling and venous engorgement in the neck and the chest, shortness of breath. There may be difficulty in swallowing, hoarseness of voice. So these are the common symptoms. And regarding SVCO, we need to remember one thing. It is not a medical emergency, it is an urgency. So before embarking on any treatment, we have to prove histologically that what is the reason leading to this superior vena cava obstruction. Before starting any empirical therapy, we should be very careful in establishing the diagnosis first, because in non-small cell lung cancer and small cell lung cancer or other types like lymphoma, the management protocol is entirely different. Another is the Pancoast syndrome. Pancoast syndrome is, as you all know, this is mostly the superior sulcus tumor. Is the presence of the tumor in the apex of the lung, and it may lead to the shoulder pain due to the involvement of the ribs and the intercostal nerves, and there will be Horner's syndrome. And mostly these tumors are non-small cell. I forgot to mention that the superior vena cava obstruction mostly seen in the small cell lung cancer, but Pancoast syndrome mostly there due to the non-small cell carcinoma, mostly squamous cell carcinoma, and mostly the stage group, sorry, the staging in this particular Pancoast syndrome, superior sulcus tumor will be mostly at least T3. So here we obviously can see the location of the tumor leading to the compression of the nerve roots and the vessels. Common sites of the lung cancer metastasis. So lung cancer, as you all know, they're very much prone to get metastasized, and apart from the regional spread to the lymph nodes, like the mediastinal nodes, supraclavicular nodes, and axillary nodes, the visceral spread is also very commonly seen. The common sites of metastasis are the brain, liver, bone, and as well as the adrenal gland. So symptoms due to the metastasis, like the brain metastasis, the patient may present, as you all know, with the raised intracranial tension like headache, vomiting, loss of balance. There may be personality changes and weakness, convulsions like that. And symptoms due to the bone mets, there may be bone pain, there may be spinal cord compression leading to weakness of the extremities, which is obviously an medical emergency, and it may lead to hypercalcemia. Symptoms due to liver mets, as you all know, there will be jaundice, nausea and vomiting, loss of appetite. Paraneoplastic syndrome, for adenocarcinoma, the commonly associated paraneoplastic syndrome is the hypertrophic pulmonary osteoarthropathy, and the squamous cell carcinoma is associated with the hypercalcemia of malignancy, and the small cell carcinoma, it will mostly linked with the syndrome of inappropriate secretion of the antidiuretic hormone, and also the ectopic production of the adrenocorticotrophic hormone leading to Cushing syndrome. There are some other rare phenomena like the cerebellar degeneration, Lambert-Eaton myasthenic syndrome. So these are the paraneoplastic syndrome that may be associated with various types of the lung cancer depending on the histology. Now coming to the staging, for the staging of the lung cancer, we follow the 8th edition of the AJCC staging, and this modification has been done by the inputs from the ISCLC, that is the International Association for the Study on the Lung Cancer. And there are some important changes in the T stage and the metastatic staging in the lung cancer. And regarding the stage, I don't want to go to this busy slide, rather I will explain with the CT finding. Like obviously, apart from the TX, which is basically primary tumor cannot be assessed, or TX can also be defined in cases where there is presence of the malignant cells in the sputum or the bronchial alveolar lavage fluid, but there is no malignancy can be found. No definite evidence of the malignancy is found by the imaging or the bronchoscopy. And T0 is no evidence of the primary tumor. And coming to the TO1, TO1 is the tumor size which is not more than 3 centimeter, and it has to satisfy all the criteria, like it needs to be surrounded by the lung parenchyma or visceral pleura, and it may involve the lobar bronchus, but the involvement may not be, shouldn't be beyond the lobar bronchus. That means it shouldn't involve the main bronchus. And there are 4 types like TO1A. One is the microinvasive or the minimally invasive carcinoma. Mostly minimally invasive carcinoma are the T size of not more than 3 centimeter with depth of invasion is less than 5 mm. And next TO1A, where it is an invasive carcinoma, but size wise it's not more than 1 centimeter. T1B, where the size will be 1 to 2 centimeter, and T1C is 2 to 3 centimeter. Next, coming to the T2, here the size is 3 to 5 centimeter, and or with any one of the following, like involvement of the main bronchus, regardless of the distance from the carina. It has some importance that I will discuss later. There may be invasion of the visceral pleura, or atelectasis or post-operative obstructive pneumonitis extending to the hilum. And there are 2 types depending on the size. T2A, it is more than 3 centimeter but not more than 4 centimeter, and T2B, which is more than 4 centimeter but not more than 5 centimeter. In this picture, we can see a collapsed lung, and as well as we can see there is involvement of the main bronchus, but obviously the carina is not involved. Next, coming to T3, the size criteria wise, it is more than 5 centimeter, but not more than 7 centimeter in greatest dimension, or tumor of any size, irrespective of size, if it has the following features, like invasion of the chest wall. We can see a yellow arrow clearly demarcating a chest wall invasion, or invasion of the pericardium, invasion of the parietal pleura, phrenic nerve invasion, invasion of satellite nodule in the same lobe. This also we can identify by a small white arrow where there is a satellite nodule is found in the same lobe. Next, coming to the T4, T4 is more than 7 centimeter in greatest dimension, or any tumor with invasion of the mediastinum, which is clearly visible in this CT scan picture, or involvement of the diaphragm, and involvement of the heart, great vessels, rectal-laryngeal nerve, carina, involvement of the carina, and involvement of the adjacent structures like the trachea, esophagus, vertebra, or a separate tumor nodule in different lobe of the ipsilateral lung. Any presence of any one of the following is sufficient to categorize the tumor as T4. End staging, fortunately, there is no major changes in the clinical end staging in the latest classification. In end staging, the NO1 means the hilar nodes of the peribronchial nodes, they're involved ipsilateral, and N2 means metastasis in the ipsilateral mediastinal or subcarinal lymph nodes. N3 means metastasis in the contralateral mediastinal or hilar and ipsilateral contralateral supraclavicular lymph nodes. Now let me explain. This is a basically this mediastinal lymph node staging is commonly we find the reference from the ISLC. They have divided the mediastinal nodal classification into 7 broad zones. One zone is the supraclavicular nodal zone, supraclavicular zone, which is the level 1, which is clearly seen in this picture. That is the level of 1. And next, the upper zone of the superior mediastinal nodes. Here, as per the latest ISLC zonal definition, level 2 to level 4 will be the superior mediastinal nodes. Next, coming to the aortic nodes. Aortic nodes are along the in the aortopulmonary window region, the level 5, station 5, and the para aortic region, that is the station 6. Subcranial zone is a separate zone now, which is basically level 7. And next, there are hilar region. These are basically the pulmonary nodes where the hilar and lobar nodes are there. That means 10 and 11 nodal stations will be within that hilar region. And another is the peripheral zone, where you see these are also pulmonary nodes, but they are much peripherally located. These are basically 12 to 14. So these are total 14 lymph node stations we are describing. So if this metastasis is in the ipsilateral station 10 to 14, that means ipsilateral peribronchial, the subsegmental, segmental, lobar, interlobar, or hilar nodes are involved, then the stage will be N1. Next, if the mediastinal nodes or the subcranial nodes are involved ipsilaterally, it will be basically N2. So station 2 to 9. And N3 will be contralateral level 14 to 2, or ipsilateral supraclavicular, or irrespective of ipsilateral contralateral supraclavicular lymph nodes. That means level 1 will be sufficient to upstage as N3. So this is the basis of the N station, and there is no change in the N stage. But as far as I remember, there is some change in the pathological nodal staging, where the number of the nodes are incorporated, like N2A and N2B, N1A and N1B. That means N1A means only one node is involved pathologically, N1B means multiple nodes are involved. Obviously, there is a difference in survival. That's why this kind of staging assignment has been done. And the M stage, there are some changes in the M stage. M0, as you all know, no distant mates. M1, there will be distant metastasis. M1A is separate tumor nodule in a contralateral lobe. That means the opposite lung, there will be nodules, satellite nodules, or tumor with pleural nodules, pericardial nodules, or malignant pleural or pericardial effusion, will be M1A. M1B will be single extrathoracic metastasis in a single organ. Like suppose there is a single focus of mets in the liver, so it will be a M1B. But one thing we should remember, that before depriving a patient diagnosed with M1B from any radical treatment, we should confirm that there is a definite evidence of metastasis. And after, if possible, by doing biopsy or FNAC from that site, we need to confirm that there is presence of metastasis. And ideally, it should be confirmed before depriving the patient from any radical treatment. And M1C means there is multiple extrathoracic metastasis in one or several organs. That means there may be in liver, there may be multiple mets, or there may be metastasis in liver, metastasis in bone, metastasis in brain, like that. So it will be obviously upstage to M1C. So now coming to the important point, that is the changes from the 7th to 8th edition and why these changes are necessary. Like in T1 at present, there is T1 ABC. That means less than 1, 1 to 2, 2 to 3. Before that, in T1, there is only T1A and T1B, that is less than 2 to 3 centimeter. Like we can see that T2A and T2B, the subclassification is same. The size criteria, as we can see, is different. Like T2A is at present is 3 to 4, and T2B is at present 4 to 5. Previously, it was 5 to 7. Now T3 is now more than 7. And sorry, my mistake. So T3 will be now 5 to 7 and T4 will be more than 7. So why there is these changes are there? Because it was seen that ISLC they have conducted from 2000 to 2010 or 11. They have taken data from around 70 to 80,000 patients of lung cancer, and among them around 70,000 patients were of in SCLC, 10,000 patients were of small cell lung cancer, and it was seen that with increment in the size, like from 1 to 2 centimeter to 3 centimeter, 3 to 4 centimeter, there is a sharp decrease in the rate of 5-year overall survival. Like in a T1A tumor, 5-year survival may be as close as 94 to 95%, but when it is T1B, like 2 centimeter, 1 to 2 centimeter tumor, the survival drops like 90 to 86 to 90%. Next, T1C, it may be 80 to 85%, like that. So there is a rapid decline in the rate of survival. So that's why the size criteria has been redefined. And another important thing is that in previously in the T2 staging, there was involvement of the main bronchus was there in the T2, but there was a distance specification. That is, it was more than 2 centimeter from the carina, and the lesions will be upstairs to T3 if the lesion was more within 2 centimeter from the carina. But that demarcation is not there, because the reason being, if we see the other criteria of the T3 tumors, the survival of a tumor which is basically within 2 centimeter of the carina is more superior compared to the other T3 defining criteria. So it has been downstaged to the T2. That means distance from the carina, it doesn't matter anymore. Only thing is that carina shouldn't be involved. If carina is involved, then it will be T4. Another thing is that for the same reason, the atelectasis, whether the part of the lung is involved or the whole lung is involved, it doesn't matter. It is in the T2 classification. And another important thing is the previously in the diaphragmatic invasion was in T3. Currently, it is in the T4 because it was seen that the patients who have diaphragmatic invasion, they're prognostically they're faring much worse. Their survival is much worse compared to the other T3 defining criteria. So they have been upstaged. And in staging, as I have mentioned, there are no changes. And in M1M classification, there is significant change like M1B and M1C. Obviously, it is necessary that a patient with a single extrathoracic mates and with multiple extrathoracic mates, particularly in the era of stereotactic radiation therapy, there has to be a discrimination, both in terms of prognosis, both in terms of treatment option. So this classification, these changes are quite justified.
Sir, sorry to interrupt you. Kindly try to wrap up within the next 5 minutes.
Okay.
Thank you.
So these are the survival rates that I have already informed. And next, coming to the workup history and physical examination, as I've already mentioned, the blood investigation, CT chest and upper abdomen, PET CT, bronchoscopy, and bronchoscopy guided procedures like US and EBUS, and thoracentesis, mediastinoscopy, thoracoscopy, as well as MRI brain. It is very important in the workup. Blood investigations, we all know the basics, so I am not elaborating the blood investigations. Coming to the CT scan, mostly whether the chest X-ray is done or not, sputum cytology done or not, in a patient where we are suspecting a lung malignancy, CT scan of the chest and upper abdomen is the very first investigation that we need to do. And the upper abdomen portion, it should include the entire liver and adrenal gland. Obviously, we need to emphasize on the IV contrast because there will be better delineation of the primary tumor based on lymphadenopathy. and also determination of the staging. That means the T-staging determination we can do, as well as the nodal staging we can do from the CT scan. Although the shortcoming may be a less sensitivity and specificity of the CT scan for the mediastinal nodes, like only 60 to 60% sensitivity and specificity of 80%. And CT scan helps in the establishment of the histological classification, like CT guided FNAC and biopsy for the peripherally located lesion is a very widely practiced protocol, and CT scan is the very is an imperative part of the radiation therapy planning, as we all know. And CT scan, one important shortcoming is that we cannot accurately differentiate between the atelectatic lung from the primary tumor. This is a picture showing am I audible now?
Yes, yes, sir, audible.
Okay, and next is the next important investigation is the PET CT scan. PET CT scan is the standard staging workup. It is very commonly used. The main advantage are that differentiation between the atelectatic area and the tumor, and mediastinal lymph node staging is more accurate, and distant metastasis we can detect, and sensitivity specificity of mediastinal nodal mets in PET CT is around 80% and 90% respectively, as per a meta-analysis. And it aids in precise contouring of GTV, particularly identification of the atelectatic area. And shortcomings are there is still a very high risk of false negative rate, around 25% of the lymph node, 25% in lymph node which are subcentimetric, and there may be a false positive rate of PET CT scan. So if PET CT is detecting any nodal mets, so before omitting any radical treatment like surgery or SBRT, we should confirm it by a mediastinoscopy or the EBUS US, which are much less invasive procedure, that whether that lymph node is lymph nodes are involved or not. But in some cases we can forego PET CT, we can forego these invasive tests, like suppose a peripheral tumor stage 1, like less than 3 to 4 centimeter in size, which is PET positive, but mediastinal nodes are not PET avid. In these cases, we can forego US or EBUS or mediastinoscopy for the mediastinal assessment. And pleural fluid drainage is very important for the therapeutic purpose, for providing relief from the shortness of breath, and as well as for establishing that whether that pleural effusion is malignant or not. The fluid may come on repeated aspiration, it may come as negative, but a negative pleural fluid cytology doesn't mean that it is not a malignant pleural effusion. We need to also emphasis on the color of the fluid. If it is a hemorrhagic fluid, there is a very high risk, high possibility that this is due to the metastasis. Sorry, due to this is a malignant pleural effusion, and sometimes we may take help of the thoracoscopic evaluation or pleural biopsy as well. Bronchoscopy.
Sir, please try to.
I'll just take another.
Okay. Sorry, sir. Thank you.
So bronchoscopy, it is very important for the centrally located tumor for taking biopsy, and this is a bronchoscope and the bronchoscopical picture, as I have here I have mentioned. And the bronchoscopical guided procedures are the endoscopic ultrasound, and like the endoscopy, endobronchial ultrasound and guided transbronchial needle aspiration from the nodes. These are much less invasive procedure compared to the mediastinoscopy. and endoscopy, endoesophageal ultrasonography. They're basically complementary to each other. Like just I want to say that the upper and lower patriarchal group of lymph nodes, subcranial group of lymph nodes, hilar group of
Hello, Shomodeep, you got just muted. Please unmute yourself.
Hello. Hello.
And audible, sir. Now audible, sir.
Now it's me. Jiva. Shomodeep.
Hello.
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 So, sir, it is muted.
Okay. Sorry.
Please unmute yourself.
So now am I audible?
Yeah.
So
Yes.
yes. So another important is the mediastinoscopy. I am just showing the picture. The upper and lower paratracheal and hilar group of lymph nodes are visualized here, and commonly the aortopulmonary window lymph nodes, they are not visualized. So for that we need to extend the mediastinoscopically to an anti-mediastinoscopy approach. Thoracoscopy is it is used in various purposes like diagnostic, staging, and resection of the lung cancer. And so this is thoracoscopic lung biopsy. Now the take-home messages are that lung cancer is the most common cause of malignancy and in male, and it is the common cause of cancer-related death. It is mainly related to the smoking. And broadly, there are two types: non-small cell and the small cell. And EGFR mutation is the most common driver mutation in NSCLC, against which TKI therapy is there. And common symptoms, as we have discussed, common site of metastasis. And currently, we follow the JCC 8th edition. And CT scan, PET CT scan, bronchoscopy, endoscopic ultrasound, and guided FNAC. And in some cases, mediastinoscopy and video assisted thoracoscopy, they are commonly performed investigations for the lung cancer. And last but not the least, currently a stage 2 to stage 4 lung cancer, before embarking on any tumor, ideally MRI brain should be performed. So thank you.
Thank you, sir, for your lucid lecture. Our next speaker is Dr. Moses Arun Singh, consultant clinical oncologist from Tata Medical Center, Kolkata. Sir will enlighten us about the treatment of non-metastatic disease in lung cancer. Moses, sir, please proceed.
Yeah, I'll just share my screen.
Okay, sir. Yes, sir, it's visible.
Yeah. Okay. Thank you for inviting me to talk on this topic. So for the next 20 to 30 minutes, my mandate is to cover the whole of the treatment of non-metastatic disease. So it is impossible to go into all the nitty-gritties of every setting. So I'm just going to take you briefly through the evidences. I'll just point you towards the evidences. Those who are interested, they can go through the references that are put on the slides. So I've split my talk into two parts. The first part, I'll cover the treatment for non-small cell lung cancer, and the second part, I'll cover the treatment for small cell lung cancers. And in non-small cell lung cancers, I will just touch upon radiation therapy to begin with before proceeding to systemic therapy. So radiotherapy, as we all know, forms an important part of treatment in non-metastatic disease in the management of lung cancers. And in anyone who doesn't have a metastatic disease, we would offer them radical treatment. If they are surgically treatable, they would be offered surgery. And I'm not going to go into surgical treatment today. So in anyone who is not eligible for surgery, they would be offered a treatment with radiotherapy. So there are, as we know, there are different ways of delivering radiotherapy. In terms of fractionation. So one of the commonest fractionations that we use for treatment of lung cancers is conventional fractionation. So, and with that, 60 gray in 30 fraction has been the standard of care for nearly the last 4 decades. and how did it come to become the standard of care, and why has it stayed so for so long a time is what I'm going to talk about in the next few slides. So this was a trial which looked at dose finding exercise way back in the 1980s. So it looked at escalating doses in conventional fractionations, and for a good measure, there was a split course as well put into the put into the trial. So what this trial essentially showed was if you give higher doses in conventional fractionation, that results in better local control rates. So you can see that the arm 3, which delivered 60 gray in 30 fraction, was the one which had the least local failures at 3 years. So, and that established 60 gray in 30 fractions as the standard of care way back in 1980. But we also had evidences from several publications that there is a role for, there is a dose response relationship in the treatment of lung cancers for increase in radiotherapy doses. And this is well established by this meta-analysis, which looked at more than 1,000 patients from various RTOG trials, which looked at lung cancer radiotherapy, and showed that for every 1 gray biologically effective dose increased, it impacts at in the overall survival by 4%. This is a 4% relative increase for every 1 gray biological effective dose increase. And also it has an effect on the loco-regional control as well. So there is clearly a rationale for dose escalation, but all attempts since that RTOG trial that I showed you just now failed miserably, till the arrival of modern techniques like 3D CRT and IMRT showed promising opportunity for dose escalation. So that led to the famous RTOG 061 trial being designed with the hope that with the modern techniques available, dose escalation would be feasible and lead to a meaningful improvement in outcomes. This trial also looked at establishing whether cetuximab, in addition to radiotherapy, would be beneficial. But this trial, as we all know, threw up an awful surprise in that people who received a higher dose ended up having worse survival than those who received the current standard of care, that is 60 gray in 30 fractions. So why did the RTOG 06117 fail? Several postmortems were conducted, and several interesting theories, hypotheses were proposed. One of them could be that it was because of accelerated repopulation, because we ended up delivering the treatment over a longer period of time when we escalated dose. That could have been a cause, or it could be because of higher cardiac toxicity with higher dose being delivered to the thorax. Esophagitis for the first time was linked to poorer overall survival. And IMRT was not mandated in this trial. If someone wanted to do IMRT, they were eligible to do it. So people who had larger tumors ended up getting IMRT, and smaller tumors getting 3D CRT. So one of the things that was thought about was whether a uniform use of IMRT would have resulted in better survival. Or while thought would be 60 gray the limit, but this is unlikely looking at all the previous evidences. There was also tantalizing evidence that possibly the experience of the treating centers also mattered in dose escalation. So all said and done, after all these, 60 gray in 30 fractions still remains the standard of care in conventional fractionation until it is proven otherwise. But what about altered fractionation? So we have, like I said earlier, in radiotherapy, we have the ability to manipulate the way we deliver dose per fraction. And one of the way to do that is by hyperfractionation. So just as the cancer is continuously multiplying throughout the day, we oncologists also thought that if we also work throughout the day, maybe it will be better for cancer control. So this was one large trial which was run in the United Kingdom. More than 563 patients were randomized to conventional radiotherapy versus continuous hyperfractionated accelerated radiotherapy. This is delivering 3 fractions in a day. and also delivering treatment over the weekend and completing the entire treatment in just 12 consecutive days. So you can see that it is a very resource intensive procedure in that the patient has to come to the hospital 3 or stay admitted in the hospital to receive 3 times the treatment in a day. And also the staff have to be ready to work over the weekend to make this happen, because there was another trial which tried delivering this same treatment without the weekend and failed miserably. So the only treatment with a hyperfractionated acceleration works if it treated over the weekend. So what this trial showed was, over conventional radiotherapy alone, there was a significant benefit, that is an absolute benefit of nearly 9% at 2 years. And this benefit was seen more in the squamous cell cancer group. And also with any attempt that we do to improve outcomes, we are going to face toxicities, and that is what was seen in this as well, that the chart group had was acute dysphagia. But with longer term follow-up, this did settle down. So this is one option that we have for patients who cannot undergo conventional treatment with chemotherapy. Just a second, I'll just take some water. So as I said, it is a very resource intensive process. So the question remains whether it is applicable in the real world. So here is a slide which shows our modest effort because of the logistic issues that I just mentioned. It had to be abandoned in our hospital, and this the charts on the right side shows the results of a large audit that was conducted in the UK. So the other way of doing altered fractionation is hypofractionation. Unlike the other altered fractionation, this fractionation regimen does not really have large randomized evidence comparing it against hypofractionations. But it has been used for a long time the world over. So in one of the randomized trials, which was looking at a different question of concurrent versus sequential chemoradiation, this was the standard radiotherapy regimen used, and it did not show significant toxicities. And this was in the era where modern techniques like IMRT and 4D radiotherapy were not available. And this is a large retrospective audit published from the United Kingdom. If you look at it, it's more than 600 patients, and majority of the patients had received concurrent radiotherapy with concurrent chemotherapy with a hypofractionated regimen of 55 gray in 20 fractions. More assuringly, there was no significant grade 3 or more toxicities in this group. So what about dose escalation in this setting? So we saw that accelerated repopulation could be a problem when we prolong treatment. So people are now looking at shortening the treatment and at the same time dose escalating it. So several attempts have been done. So 2 phase 2 trials, at least one is the ideal CRT and the iStart trial. Both have managed to escalate a dose to a high dose in a hypofractionated setting. With acceptable high-grade toxicities. So this is likely to be the future of dose escalation for lung cancers and not the conventional fractionation. So we have all these evidences. So we always, as oncologists, fall back on meta-analysis to reassure us that that is the evidence that we have seen with the randomized trials are actually true. So there is a meta-analysis of nearly 10 trials, including more than 2,000 patients, where modified fractionation was compared with conventional schedules. And this definitely showed an improved overall survival with an absolute benefit of 2.5% at 5 years. And definitely this is at the risk of an increased esophagitis risk from 9% to 19% with hypofractionation. And regarding the volumes of radiation, earlier in the before the modern era, earlier when 2-dimensional radiotherapy was being practiced, it was common to include the whole of the mediastinum and treat it as elective nodal treatment. But there were several reports which showed that there is no need to electively treat these nodes, and the elective nodal failures are very, very less. So this is a more recent meta-analysis which included 3 randomized control trials and 3 cohort studies of nearly 1,500 patients, and it showed that there is no significant difference in terms of elective nodal failure, whether we treat the elective nodes or just treat the involved nodes when we are delivering radiotherapy. So in the modern era, there is no role of elective nodal radiation. What about adjuvant radiation therapy? So in the past, for anyone with a very advanced disease who has undergone a surgery, they would be given radiotherapy. But just around the turn of the millennium, this meta-analysis showed that people who received adjuvant radiotherapy, they were likely to have worse overall survival. And this was seen more in people who had early stage diseases like stage 1 and stage 2, with stage 2 faring much worse than the stage 2. But this meta-analysis did not show any clear evidence of detriment in stage 3. So it was always argued based on other large database reports that in possibly this subgroup of patients, there is a role for postoperative radiotherapy. And because radiation techniques have improved a lot, a more recent randomized trial was designed for that, and it tested out this concept. So here, patients with proven pathological N2 disease were randomized to adjuvant postoperative radiotherapy versus no postoperative radiotherapy. Even with the use of modern techniques like 3D CRT, this showed that the 3-year DFS was not any different, but the 3-year overall survival was definitely worse in patients who received postoperative radiotherapy. So it seems that the toxicity outweighs any benefit that can be received from postoperative radiotherapy in N2 disease patients as well. So currently, there is no role of postoperative radiation therapy for any lung cancer patients, apart from possibly patients who have R1 and R2 resections. So coming to a very niche group of radiotherapy, that is stereotactic radiation. So this is a precise focused way of delivering radiotherapy for people with early stage lung cancers. So the current eligibility would stand something like this, who have 5 centimeters or less than that in size of the primary tumor, with nodes being negative by PET imaging and mediastinal staging, and those who are not eligible for curative surgery or who are not willing for surgery, they would be offered radiotherapy. There's a huge body of evidence that is present, that has been published for SBRT in lung cancer. So if you just search with these terms in PubMed, these are the amount of results that would come up. But just because we have the so many publications, does it mean that it is effective? So this is a systematic review of nearly 5,000 patients who have been published in literature. So they showed that these patients have good overall survival. So the survival is dismal towards the end as we have longer follow-up, because these patients were are the patients who were selected to receive radiotherapy only because they were not fit enough to receive surgery. So they did have other comorbidities. That is why the long-term survival is less compared to surgical groups. But if you look at the local control, excellent local controls reaching 90% and above, with acceptable toxicities. So the grade 3 and grade 4 toxicities range somewhere between 2.7% to 27% in the all the publications. And the most common toxicities that are reported are pneumonitis, dyspnea, chest pain, and pneumonia. So, but I've showed you all these retrospective data that have been published. Is there a randomized evidence? This is a question that all good oncologists should ask for any question that we face. SBRT in lung cancers faces a two-pronged war at two fronts. One is against surgery and the other is against conventional radiotherapy. So there have been several attempts in the past to conduct trials against surgery, but because of preferences of the treating oncologists, it was not possible to complete all these trials. So the two trials that were conducted, they pulled together whatever patient that they could randomize. It was just 58 patients, and they showed that possibly there was no difference between the two groups, but the very small number of patients, very underpowered to conclude anything from these reports. But there are again multiple attempts to do further randomized trials against surgery. Sabertooth is something that was tried out in the UK again, but it could not be completed because of patient preferences and treating physicians' preferences. But across the pond, they are again in the US, they are again trying to do more trials. The stablemates and Whaler are open to recruitments, and maybe they will give us some idea. On the other front, Saber needs to be compared against conventional radiotherapy as well. So we have two trials. One is a phase 2 space trial, which did not show any difference over a conventional radiotherapy with a Saber dose of 66 gray in 3 fractions compared with 70 gray in over 7 weeks. It did not show any difference. Whereas another trial, similar number of patients, but a phase 3 trial with a Saber dose of 54 in 3 or 48 in 4, compared against 66 in 33 versus or 50 gray in 20 fractions, showed better local treatment, local control rates, and better median overall survival as well for favoring SBRT. There are several criticism about these two trials, but all said and done, based on these evidence, it can be said that for someone who is not eligible for surgery, SBRT is it could be offered as a standard option, considering the less number of fractions and also favorable toxicity profile that have been reported from these trials. So with SBRT, there are some things that we need to keep in mind because we are delivering very high doses of radiation per fraction. In a small number of sittings, the location of the lesion becomes very important. In peripherally located tumors, it is easier to deliver SBRT because it is surrounded all around by pulmonary tissue, which is a well-known parallel organ. So even if you knock out all the lung around that, the rest of the lung, which is still functioning, can take over the function of that knocked out lung. But if the lesion is located in the central, near the central airways, which are serial organs like the main bronchi, trachea, blood vessels, esophagus, wherein if you knock out even just a part of these organs, it can lead to significant toxicities, fatal toxicities as well. So for the peripherally located tumors, we have a wide range of dose fractionations to choose from, and all of these are well established. So the only thing that we need to keep in mind is to choose a dose fraction which has a BED of 100 gray or more, because that has been shown to have better local control rates and survival rates compared to dose BED less than 100 gray. For the centrally located tumors as well, the problem happened because of this. Several high-profile publications happened. So this was one of the first warning publications to come out for central lung tumors, which reported a fatal toxicity after SBRT for centrally located tumors. So based on these publications, we ended up drawing this boundary line around the central airway and decided that any gross tumor volume which falls within this 2 centimeter zone would not be eligible for SBRT. And that remained so for a long time. And now people are slowly exploring options to deliver SBRT for this group as well. But that boundary line, like all other boundary lines in our world, has been defined in different ways by different groups. And we just have to choose one and stick with it. And if you go look at various guidelines that are published as well, All of them caution against a caution about SBRT in central lung tumors. And there is a further classification of an ultracentral lung tumor wherein the GTV is in touch with the central structures, wherein SBRT is absolutely advised against outside of clinical trials. So again, we have several dose fractionations which have been published for these central lung tumors as well. So if at all you have to deliver SBRT for these patients, then you would choose from these dose fractionations, which are deemed to be slightly safer compared to other dose fractionations. What about patients who do not have a metastatic disease, but who are not eligible to receive radical treatment with radiotherapy? So in these patients, and there is a large MRC trial that was conducted in these group of patients, wherein they compared a higher dose fractionation with a lower dose fractionation, and found that people who receive high dose of radiotherapy to the thorax, they have a longer time to failure with distant metastasis, although the treatment, failure within the thorax was not any different. But the catch is that people who receive higher radiotherapy dose obviously had longer duration of dysphagia as well. So this is something to be kept in mind. So if it is feasible to deliver a higher dose of radiotherapy for even for patients who are not fit enough, that should be considered. What about particle radiotherapy? This is something up and coming and very much advertised as well. We know that for particle treatments, there are several advantages, physical advantages. So the theoretical advantages are that because we can make the radiation to stop at a particular point within the body, it allows to deliver a more focused dose of radiation to the tumor with less exposure to the surrounding tissues. But what does the evidence say? This was a meta-analysis for early stage lung cancers where SBRT was compared against proton beam therapy. It did not show any difference between the two groups, with toxicities in terms of pneumonitis being worse with SBRT, whereas the chest wall toxicity was worse with proton beam therapy. So there is no clear evidence that proton works better in early stage lung cancers. There was only one phase 2 RCT that was tried out, but closed due to poor accrual. What about in locally advanced non-small cell lung cancers? There's one phase 3, this is a phase 2 randomized trial, a different kind of a design. So they tried out this randomized trial and showed that the toxicity rates or the local failure rates were not any different between the two groups. But obviously the cardiac sparing was better with proton therapy. So this is being further tested out in another RTOG trial as well. So we will have to wait for those. Sorry, that should not be coming up. Anyway, so to summarize about radiotherapy in non-small cell lung cancers, so if at all anyone is not fit for radical treatment, you offer them a higher dose of palliative radiation. And for anyone going for radical treatment, if we treat with conventional radiation, it should be 60 gray in 30 fractions. And if they are unable to receive concurrent chemotherapy or sequential chemotherapy, then consider for chart kind of hyperfractionated therapy. And if that is not feasible because of logistic issues, then the other alternative option is to go for hypofractionated radiation. If this can also be used in the sequential setting where you want to avoid a prolongation of treatment. And for early stage lung cancer patients, if not operable or not willing for surgery, offer them stereotactic radiation. Use caution when treating central lung cancers. And when it comes to chemotherapy, why do we need to add chemotherapy? Because several randomized studies have been conducted, and a meta-analysis definitely showed that adding chemotherapy in lung cancers to the radiotherapy definitely improves the survival, but at the cost of higher toxicities. And these toxicities were seen more with the concurrent patients than with the sequentially treated. But that brings us to the question of whether we should give it concurrently or sequentially. So this was another meta-analysis, more than 1,000 patients. Again, it was shown that concurrent treatment is contributing to more better overall survival than sequential chemoradiation. But again, concurrent patients would have higher toxicities compared to people who are receiving sequential chemoradiation. So how do we choose a concurrent chemo regimen? So what makes a good concurrent chemo regimen? They should have good radiosensitization, favorable toxicity profile so that we can deliver the entire treatment, and it should be easy to administer for the oncologist, and also possibly have good systemic efficacy as well, because we know that lung cancers do fail with distant metastasis. Sorry again. So for the ideal choice of concurrent chemotherapy, there has been a toss-up. It's been a constant fight between two regimens of cisplatin etoposide, which used to be the standard for a long time. But for ease of use, carboplatin and paclitaxel has also been tested in many trials. And these are two commonly widely used regimens. But choosing between the two, it is still very difficult. There is only, I think, possibly one randomized trial which shows that possibly cisplatin etoposide scores over carboplatin paclitaxel, and the guidelines also mention that if there are no other contraindications, the chemotherapy should be based on cisplatin. In the immunotherapy era, wherein locally advanced patients would go on to receive maintenance immunotherapy as well, radiation pneumonitis is something that we need to keep in mind. And with concurrent carboplatin and paclitaxel, it has been shown that grade 2 or more radiation pneumonitis is higher in this group of patients. So when it comes to sequential chemotherapy, we are spoiled for choice because we have very a large number of choices. We can take cue from the metastatic setting and choose regimen as per the histology that is present. We usually give 3 to 4 cycles and then reassess for radiation therapy. Many people practice consolidation chemotherapy, especially when delivering treatment with weekly carbopacly, but these are delivered with good intentions, but backed by absolutely zero level 1 evidence. What about consolidation targeted therapy? Geftinib has been tried and possibly showed worse outcomes, but although this trial tried it out in a unselected population, so people who were EGFR negative are also given Geftinib, possibly that could have resulted in the worse outcomes. So there are newer trials testing it out in selected populations who are positive for driver mutations with EGFR. With cetuximab, again, no benefit. And again, with bevacizumab, it can lead to fatal toxicities. What about a brief word about immunotherapy? This is something that has changed the picture a lot in the recent years. The Pacific trial, wherein people who did not progress after CTRT were randomized to receive a year of maintenance immunotherapy versus placebo. And it showed that definitely the median survival reached about 4 years, with the 4-year overall survival update also showing that the durvalumab group, nearly 50% of them are surviving, compared with only 1/3 in the placebo group. So offer durvalumab to anyone who is not progressing after CTRT once the side effects are settled down. In the trial, they started before 42 days, but based on real world data, it is possible to start later than 42 days as well. The trial as such did not answer the question of whether in patients with driver mutations, durvalumab would be beneficial, but it is questionable. I mean, I'm extrapolating from other data in the metastatic setting. So to summarize systemic therapy, chemoradiation is better than radiation alone in stage 3 lung cancers. Sequencing, concurrent superior to sequential at the cost of increased toxicity. Concurrent chemo is a toss between cisitop and carbopacly, and offer immunotherapy for maintenance treatment. So moving on to small cell lung cancer treatment. First up, with thoracic radiation. So what is the need for thoracic radiation? So meta-analysis of nearly 2,000 patients showed that adding radiotherapy to someone who's receiving chemo for small cell definitely gives a 5-year overall survival percent of nearly 5%. And the patients who are younger definitely did better than the elder patients. But should we give it concurrently or sequentially? Again, this was one trial which looked at this. So again, this was a 45-gray twice daily radiotherapy with the radiotherapy being delivered concurrent with the chemotherapy or sequentially. So showed that concurrent chemotherapy yielded better survival and even with longer follow-up, but at the cost of higher hematological toxicities. But this is another trial, so which looked at concurrent. So this is a this is a meta-analysis which looked at concurrent versus the timing of the radiotherapy. So what it showed was the what mattered most was the time from the start of the systemic therapy to the end of the radiotherapy. So regardless of when you start the radiotherapy, if you are able to complete the radiotherapy within as short a time from the start of the first cycle of chemotherapy, that is what matters most for the survival benefit. So, but again, when we do this, the toxicity is going to be higher. So, the question of whether a twice daily radiotherapy or once daily radiotherapy is better for small cell lung cancer treatment has been there for quite a long time. So around the turn of the millennium, this was the THORACOSCOPY trial, the intergroup trial, which looked at this question. And 45 in 30 twice daily was compared with 45 in 25 once daily. And it showed that the twice daily treatment was consistently better than the once daily treatment at the cost of higher toxicities. But one of the problems with this trial was the once daily treatment dose was very less, and also twice daily radiotherapy becomes a logistic issue, and the concerns about toxicities and with the availability of modern techniques, it led to the CONVERT trial being designed, which was an ambitious superiority trial of delivering higher dose of once daily treatment, with the hypothesis that this would be superior to delivering just 45 gray of twice daily treatment. But again, the trial failed miserably, and it showed that there was no benefit with once daily treatment because it was designed as a superiority trial. We cannot claim that because although the numbers look similar, we cannot claim that the once daily treatment is similar. So we have to assume that the twice daily treatment is the standard of care as of now. There are several other dose regimens that are widely used. One of because the timing from start of systemic therapy to end of radiotherapy is important. People have and for logistic issues, they have tried to hypofractionate it. So 40 gray and 15 fraction is something that is used widely based on retrospective data and older radiation trials. The other common regimen used is 55 gray in 20 fractions. Recently, there is one phase 2 trial which has shown some improvement, but needs evaluation in a larger trial because several concerns have been raised about this trial. To conclude about radiotherapy, 45 gray in 30 fractions twice daily radiation concurrent with cisplatin etoposide is the standard of care in limited stage SCLC until it is proven otherwise. So, and also,
sir, sorry for the interruption.
Yeah.
Sir, sorry for the interruption. Please try to wrap up by next 5 minutes.
Yeah, it will be over. Yeah.
Okay, sir. Thank you.
So, preferably, we should start radiotherapy as soon as possible. So, coming to chemotherapy in small cell lung cancers, we can see from all these pivotal trials that cisplatin etoposide has always been used as the backbone of treatment. So, and remains the preferred choice, and 4 cycles of treatment would be the standard of care. So I think this is the last part of my lecture, and this is about PCA. This has again been around for nearly 4 decades in lung cancer treatment. So it was established by this publication from 1981 with the aim of eliminating incidence of brain metastasis. So this is a meta-analysis, the operant meta-analysis, which looked at nearly 1,000 patients testing PCA after complete remission after chemotherapy, which showed that it resulted in a better overall survival and also decreased incidence of brain metastasis. Possibly people who had higher radiation doses had lesser incidence, but this did not translate to a survival benefit. Several trials have been conducted to find out the optimal dose, but it was not entirely feasible to conclude anything conclusively. But 25 gray in 10 fraction ended up being the choice of treatment for people who receive chemotherapy for limited stage small cell. But any good oncologist would do, people are trying to do away with this treatment because it does have its own side effect profile. So people are looking at using modern imaging techniques to see if PCI can be taken out. And even if we have to deliver PCI, whether modern radiation techniques can help with it. The one trial has not shown any benefit, and the other trial interim results are showing some benefit. So this is something to watch out for. So to summarize about small cell lung cancer treatment, PCI to be offered to anyone who has a complete response to treatment, and some guidelines also says that if they do not at least progress, even then also it can be offered. This is based on the old trials had assessed the complete response just on the basis of chest x-rays and CT scans, chest x-rays. So they assumed that some of these patients would still have had residual disease and they still benefited. So possibly those who are not progressing, all of them should be offered PCI as well. So 25 in 10 is a valid regimen, and we should balance the toxicity versus benefit in elderly people and people with vascular disorders. And radiotherapy, 45 in 30 twice daily is the standard of care. Start radiation as soon as possible and offer concurrent radiation as much as possible. And chemotherapy is cisplatin etoposide, 4 cycles of chemotherapy. With that, I end my topic.
Thank you so much, sir, for your excellent presentation. All residents are requested to ask any question. There are only one question till now. And our next esteemed speaker is Dr. Jyotirup Goswami, sir, consultant clinical oncologist from Royal Preston Hospital, UK, United Kingdom. Sir, please proceed.
Okay, thank you, Hambir.
Welcome,
So
sir.
I hope I'm audible.
Yes, sir.
Okay, yeah. Right, so I'm going to be speaking today on management of metastatic lung cancer, mainly non-small cell. I'm not actually including anything on small cell here. So this is quite a big topic, and I hope that I don't bore you to death. So we've heard about the staging in the first talk, and I just wanted to catch up with that again. So, just because we have in the audience first year residents, so it's important to understand the stage of the stage grouping. So stage 1 and 2 is the operable disease. It's mainly the surgeon's disease, so we don't really see much of these. Stage 3A also is operable disease potentially. So we as oncologists deal more with stage 3B and stage 4 cancers. We've heard about the management in the 2 previous talks, and obviously the impact of systemic therapy is more in stage 4 compared to the earlier stages. And as we lose the option of surgery, the survival rates obviously drop steeply, so that if we're looking at stage 3B or stage 4 disease, then we are really below 10%, even though there has been so many major developments in research in these stages. So I've just divided the talk into systemic therapy as well as local therapy. The local therapy will be mainly case-based and will include something on oligometastatic disease. So let's start with systemic therapy, which is obviously the base of treatment for metastatic lung cancers. Now, today we don't treat them without knowing their histology and their molecular markers. Shomadip has already spoken about the molecular markers, and as a standard of care in the UK, for example, it is customary to do the EGFR, ALK, ROS, BRAF, and PDL1, and increasingly we're looking at RET also. mainly because these are all markers which have potential treatment options linked to them. Now, thankfully, some of them are mutually exclusive. So, they don't always overlap, and therefore the option of what treatment we offer is actually made clear once we know the results. The mutations are more common in adeno versus squamous cancers. And if they are present, then usually appropriate biotherapy, which includes targeted or immunotherapy, is usually preferred over chemotherapy, though in some cases we can even use a combination. Wherever we don't have any targeted therapy options, chemotherapy is the preferred option. It's usually a platinum doublet, and we usually use 4 to 6 cycles of treatment. The goal is obviously not cure. The goal is to achieve response or even stable disease. Targeted therapies can be continued till progression of toxicity. Immunotherapy, at least in the NHS, is funded for up to 2 years, provided that the patient is continuing to respond and also to tolerate the treatment. This is just a rough idea of what the treatment options are, depending on which type of non-small cell lung cancer we're looking at. So EGFR mutated, we have all the 4 options available now. Even osimertinib in the first line is available, as well as afatinib. And of course, in the previous trials, we had erlotinib and gefitinib, which was mentioned by Shomadip. ALK mutation, not very common, but the first line option today is alectinib. For PD-L1 higher than 50%, we have the option of pembrolizumab, which is known to be superior than chemotherapy. We can use combination of pembro and chemo. The survival is equivalent, but the response rates are better. If the PD-L1 is below 50%, then the options are, again, the combination of immunotherapy and chemotherapy, which is probably superior to chemotherapy alone, but obviously it's a balance based on the patient's tolerance to treatment and whether they can go through with it. There are different other options increasingly becoming available. So other immunotherapy molecules have now come through and been approved in combination with chemo, like atezolizumab, and even dual immunotherapy like ipilimumab and nivolumab in combination with chemotherapy. So the immunotherapy, I thought we might just have a quick catch up on how it works. So unlike chemo, which actively acts against the cancer cells, the immunotherapy acts against the protective mechanisms that the cancer cells generate to protect themselves against the body's immunity. And the 2 main pathways, the CTLA4 and the PD-1 pathway. The CTLA4 is basically related with the initial antigen response. The PD-1 pathway is related with the regulation of inflammatory processes. Now, these are obviously intrinsic pathways in the body, but the tumors also carry mutations which allow them to upregulate these pathways. The pathways in situ are meant to, if you like, regulate inflammatory responses. But the long and short of it is that the PD-L1 molecule on the tumor cells bind to the PD-1 and inhibit T-cell killing of tumor cells. So obviously blocking the PD-L1 or PD-1 allows the T-cells to act, which is how all the PD-1, PD-L1 blockers have the mechanism of action, whereas the CTLA4 inhibits T-cell activation. So blocking it allows T-cell killing of the tumor cells, which is related to the ipilimumab pathway. So what are the options for treatment? Let's start with squamous. So, as I said, the first line options are chemotherapy and immunotherapy together, or just chemotherapy. If it's just chemotherapy, then it will usually include a platinum agent such as cisplatin or carboplatin, and in combination with vinorelbine or gemcitabine. Second line treatment options include docetaxel, which is a chemotherapy drug, and several different immunotherapy options such as pembrolizumab, nivolumab, and atezolizumab. For non-squamous EGFR ALK non-mutated with PD-L1 below 50%, as I mentioned again earlier, the options are chemotherapy plus immunotherapy or chemotherapy on its own. If it's chemotherapy on its own, it's usually pemetrexed and carboplatin with or without pemetrexed maintenance. If we use a combination of chemotherapy and immunotherapy, the options are pembrolizumab with carboplatin and pemetrexed, or atezolizumab with paclitaxel, carboplatin, and bevacizumab. The second line options in this setting, again, all the three immunotherapy options, if not used in the first line, or combination of chemotherapy and targeted therapy, which is docetaxel and nintedanib. On the other hand, if we have PD-L1 more than 50%, then we have the option of monotherapy with pembrolizumab in the first line, or combined with chemotherapy, or if the patient isn't suitable for immunotherapy for whatever reason, then chemotherapy on its own. The second line options are pretty much as discussed previously. And on the other side, if we have EGFR mutated tumors, as I said, all the four molecules are available in the first line. You could probably use osimertinib because it's known to produce less diarrhea and skin rash compared to afatinib, although there is a longer body of, or a larger body of experience with afatinib, and I've been seeing patients recently who have actually been on it for 7 to 8 years. Osimertinib is probably the preferred option in the second line if there is a T790M mutation, which is known to be more frequent in the recurrent setting compared to the primary setting. So a rebiopsy is quite often useful. If there is an accessible tumor, the other option is a liquid biopsy, that is a blood test. If you've had 2 lines of anti-EGFR treatment and the patient is still progressed, then the options are chemotherapy and less often immunotherapy. And finally, with ALK mutated tumors, these are much less common, but we do occasionally get one of these. So alectinib is probably the preferred first line, although crizotinib continues to be there in the first line. In the second line, it's less clear which is preferred. We know that crizotinib can be given in the second line as well, and the newer options are lorlatinib and brigatinib. But like with EGFR mutated, once the anti-EGFR, once the anti-ALK mutation treatments don't work, then we move on, or have to move on, to chemotherapy. So that was it about systemic treatment. Now let's talk about local therapy, and this includes oligometastatic disease. And I've tried to give you some cases that we can look at. So 65-year-old gentleman, known lung cancer, treated by chemoradiation, achieved complete response. Now with a gait disturbance and limb weakness, obviously brain metastases is what is likeliest, and so the MRI brain has been done, reveals 3 small contrast enhancing lesions in the left cortex. So what are the options? There's a whole variety of options, but we have to be clear based on factors like the age, the performance status, the systemic disease control, the size and the number of the lesions. 30% of cancer patients develop brain metastases, and lung cancer accounts for about 50% of the cases overall. The cases can be diagnosed at the same time, or they can be diagnosed after the primary tumor. And there's a significant number who present with a solitary lesion. The presentation varies based on the location and the number. MRI is the investigation of choice. Usually the lesions are solid, ring enhancing. They can be multiple. They're usually spherical. They're usually more common in the cerebral hemisphere. I think a lot of us training previously, and many of you are used to having brain metastases treated uniformly with whole brain radiotherapy. But there are different other situations, which I'm going to talk about now. If there is a solitary metastases, and if the tumor is controlled systemically, the options are surgical resection followed by whole brain radiotherapy with SRS boost, or even SRS on its own. Now, recursive partitioning analysis is important for brain metastases because, as I said, it depends a lot. The prognosis depends a lot on the patient's age, performance status, the status of the primary, and the number of the metastases. So the ones who do best are the ones who retain good performance status, have control primary, who are younger and who don't have other metastatic lesions, who can, who can have a median survival of 7 months or more. Whereas if the performance status is poor and if the primary disease is uncontrolled, then we're looking at really 2 to 3 months, which does obviously impact on what treatment we can think of providing. It's more appropriate today to kind of further, if you like, refine the recursive partitioning analysis by graded partitioning analysis based on the actual primary. So there are different scoring criteria depending on which primary we're looking at. But broadly, the idea is that people who are younger and have better performance status and have controlled primary and fewer number of brain metastases are going to do well. So, the overall median survival for non-small cell lung cancer can be 7 months. But if you look at people who have a higher GPA score, that is people who have all the positive factors in their favor, they can even go up to 14.8 months, which is over a year. Now, the conventional management of brain metastases, as I said, is to start medical decompression, so dexamethasone, sometimes mannitol and glycerol. If the lesions are resectable, then surgical resection and radiotherapy, and if they're not resectable, whole brain radiotherapy. But this is not really what we are at today. What are the pros and cons of whole brain radiotherapy? Obviously, it acts in a place or in a situation where most chemotherapy drugs do not work because they don't cross the blood-brain barrier. Metastases can be multifocal, so you may need something which acts on multiple areas of the brain, and you can potentially reduce the dependence on steroids. On the other side, there is the risk of cognitive decline, and there really isn't going to be a survival benefit. So today, what we're doing is we've moved to redefine oligometastases. So whereas previously it used to be up to 3 lesions with a controlled primary, I think many people are expanding this further and further to include multiple lesions, even with primary still to be treated. We've moved to replacing whole brain radiotherapy with focal radiotherapy. We've even moved to replacing surgery with focal radiotherapy. And in the surgical setting, we've moved to replacing whole brain radiotherapy or follow-up with post-operative focal radiotherapy. There are parallelly the emergence of targeted treatments which can actually cross the blood-brain barrier, particularly osimertinib and alectinib. And there is increasing evidence, especially the Quartz trial, which I'm going to speak about, which shows that there is a lack of efficacy of whole brain radiotherapy in patients with poor performance status. So when we talk about SRS, how many lesions is your cutoff? Does systemic disease status influence your choice of SRS? How to sequence it? What is the expected survival? What if you don't have SRS facilities? So these are questions which, unfortunately, even as quite senior specialists ourselves, we still have a lot of heterogeneity in opinion. But I'm just telling you that this is one of the areas where, you know, people are still, they have differences in opinion. But let's just know a few facts about stereotactic radiosurgery or radiotherapy. For a single brain metastases, 2 out of 3 trials have shown that surgical resection plus radiotherapy has overall survival and local control benefit over radiotherapy alone. There haven't been historically any randomized trials comparing surgery and stereotactic radiosurgery, but some retrospective studies have shown similar local control rates. We have now phase 3 evidence that post-operative stereotactic radiosurgery significantly improves the local regional control. And on the other side, if you tried stereotactic radiosurgery versus whole brain radiotherapy in the post-operative setting, you would have more cognitive decline using whole brain radiotherapy with no difference in the overall survival. With a single brain metastases, stereotactic radiosurgery boost has an overall survival advantage. The different modalities of delivering stereotactic radiosurgery, that is the gamma knife, the original equipment for it, or today's linear accelerators, or the X knife, they are mostly equivalent. And in between fractionated versus single dose stereotactic radiosurgery, there isn't any difference in efficacy, but we sometimes have to go for fractionated treatment where the lesions are larger or closer to vital structures. And even if you do have your targeted treatments crossing the blood-brain barrier, the best results are still with some form of radiotherapy to the brain, and usually is better with stereotactic rather than whole brain radiotherapy. Unlike other conventional radiotherapy techniques, the dose and prescription tend to depend on the size, so we can safely deliver a higher dose to a smaller lesion, but not as much of a dose if the lesion is larger. This is because we need a larger dose fall-off. And obviously, if you're treating a larger volume of tissue, then the outer rim outside of that tissue cannot be spared to as good an extent. So traditionally, for lesions up to 2 centimeter, we can use even up to 24 gray, whereas for lesions around 4 centimeter, that drops to about 15 gray. This is, of course, for single fraction SRS. And the cutoff is, as I said, around the 4 centimeter mark, though today a lot of centers are using volume-based cutoff. So rather than saying a diameter of a particular lesion, it's about the combined volume of the brain metastases. Moving on to the quartz trial, which is a completely other end of the spectrum. So these are not patients who have a limited number of brain metastases and not suitable for surgery or SRS. And this trial basically has changed practice in the UK for sure, and even I think for most of us at home, that we wouldn't now consider whole brain radiotherapy for lung cancer patients with multiple brain metastases, which are unsuitable for surgery or SRS, because there is no benefit in terms of overall survival, quality of life, or even steroid use. So that was mostly about brain metastases. I'm just going to go quickly over the rest of the cases. Some of these have been dealt with in the oncologic emergency topics. So here's the same chap who's now presented with severe low back pain, and he has multiple metastases all over the spine without any cord compression. And another chap has presented with a lytic lesion in the upper right femur. Just to say that when we're looking at limb metastases, some people do refer a lot to this Mirel scoring criteria. No orthopedic surgeon actually uses these anymore, but these are important to understand that the scoring depends on where it is. So if it's lower limb, if it's weight bearing, if it's peritrochanteric, if it's more lytic, these are lesions which would benefit with some form of prophylactic fixation because they can fracture, and that is not something we can control with any other treatment. But mostly, I think we find in practice that surgeons are very, very reluctant to engage with bone metastases if they know the patient has cancer, especially if there are multiple bone metastases. It's good practice to offer post-operative radiotherapy if the patient has had a fixation, and 30 grain 10 fractions over 2 weeks is the standard of care. Case 4 is someone who's again got pain, and this is really looking at what the best ways of dealing with pain from bone metastases is. It's nice to know that radiation has one of the highest levels of evidence out of all the different options we use for control of bone pain. I think it's pretty much standard practice now across all departments in the world to use single fractions. 8 gray is the preferred fraction size, and meta-analysis have found no difference in efficacy in terms of response, though the re-irradiation rate is actually higher if you use a single fraction versus multiple. Alongside, you would need to offer something to prevent skeletal-related events, and denosumab is preferred over zoledronic acid. There is a survival benefit, which is very minor. The rates of osteonecrosis are similar, but denosumab can definitely cause more significant hypocalcemia. But the advantage is that it can be given subcutaneously, so the patient doesn't have to come into the chemo suite for an intravenous infusion, and it can be given in people who have poor renal function, so they don't need monitoring of renal function like with zoledronic acid. We just mentioned osteonecrosis of the jaw. This is important because even though it's rare, but it can be very difficult to justify to the patient. So ideally, all patients, before they start on one of these bone protecting agents, should have a dental consultation. Bone-seeking radioisotopes, I don't think are available to us in the main, and definitely not really common for lung cancer patients because they do have bone marrow toxicity, and these patients already have had chemotherapy, so they don't really have a lot of bone marrow reserve. Likewise, for this patient, multiple bone metastases all across the body, not responding to analgesics. There is something called hemibody radiation. Again, this is not something we use commonly for lung cancer, mainly because of the lack of bone marrow reserve in these patients and their overall poor performance status. But you may find with a lot of breast cancer patients that this is actually a very useful and cost-effective means of achieving good pain relief. So it's about treating the upper and the lower hemibody in sequence, It's usually a lower dose for the upper hemibody to protect the lungs, and we usually give a gap of some weeks between the two to allow for optimal bone marrow recovery. And finally, the last patient, 68-year-old gentleman, known lung cancer, worsening back pain with neurological signs, is obviously a cord compression. I know this has been discussed earlier in one of the talks, but I just wanted to put across some of the points in the workflow. It's very important to know whether the patient has neurology or not, because if there are neurological signs, the ideal situation is to get an MRI within 24 hours. Whereas without neurological signs, but with bone pain and known bone metastases, you can even try and get an MRI within a week. And of course, once you know the patient has a cord compression, you need to treat or need to start treating them within a day. The survival depends on what kind of cancer it is and whether it's treated or not. So this is still one of the genuine medical emergencies that we as radiation oncologists have to deal with. Without treatment, the patients probably will not last beyond a couple of months. Lung cancer has comparatively poorer prognosis, and the other poor prognostic factors are multiple lesions, visceral metastases, more advanced neurological deficits, and previous radiotherapy. These are patients who probably aren't going to do very well, even with urgent radiotherapy. It's important to also parallelly give pain relief, and even before you have a scan, if you have a suspicion of cord compression, you need to start high-dose steroids, usually 8 milligrams twice a day, or even 16 milligrams once a day. It's just a point that if you are giving high-dose steroids, not to give them at night, because the patients can become really restless and uncomfortable. So it's a good practice to give them morning and afternoon. Surgery is an option if the neurological signs are less than a day old and if there is relatively better prognosis. Unfortunately, for most of our lung cancer patients, this is not true. And just to conclude with something about fractionation for metastatic spinal cord compression, the SCORAD trial has shown that single fraction is as good. So just as with bone metastases, even for cord compression, we do have the attractive option of just giving the one fraction. This is, I think, really important to know, because these are not patients who are going to do well, and the aim is not to have them in hospital or coming to hospital for any longer than you can get away with. And the final slide is for SBRT. This is not in the setting of cord compression, but rather for bone metastases in general. What are the indications, contraindications? So in general, stereotactic body radiotherapy, which is a high-dose focused radiotherapy, is an option for bone metastases where there is no fracture. There are maybe one or two segments of the vertebral column involved, and there is generally controlled primary. The idea is that a higher dose is going to achieve better pain relief and also better local regional control. So I think that is it as far as my topic is concerned. I hope I haven't gone on longer than I needed to, and I'm happy to have any questions.
No, sir. Thank you so much for your excellent talk. If any resident having any question, please ask. There are already 3 questions answered by our teachers. There is a question: should PCI by Dr. Abhay Chakraborty? Should PCI be considered in patients with small cell lung cancer? And the answer is already answered. It is, I think. Is anyone having any question? Please type your questions.
This is Dr. Abhishek Basu. Can I just make a quick comment?
Yes, sir. Please.
So, I would like to congratulate all the three speakers because they have been excellent presentations, and especially coming to the last presentation by Dr. Goswami. This was, I think, very good because this is probably the first presentation that I see where a lot of tumor-directed therapies were discussed in addition to only the systemic therapy or targeted therapies, which is often the case that most really happens when advanced lung cancer is being discussed. The comment that I want to make is regarding advanced lung cancer, and this is, I think, important because residents are here. There is an issue that is faced in resource-constrained settings like ours, where a lot of patients actually do not undergo a true-cut biopsy by which the panel of tests like EGFR, ALK, and ROS are actually done. So it's mostly an FNAC even in 2021. So this needs to be understood in the correct perspective. I just want to state why this is so important to have a proper biopsy done and then to do these tests, because Dr. Goswami has extensively told you what are the treatment options. I'm not going into that. The reason is, with any driver mutation that you have in advanced lung cancer, the quantum of overall survival benefit that comes with any of these drugs is significantly more than standard treatment, including chemotherapy and immunotherapy. So just to give you a perspective, you can push the overall survival across the 4-year milestone more than 4 years with targetable driver mutations, as opposed to about 1.5 to 2 years, which would be with chemotherapy and even with sometimes with immunotherapy, although the data with immunotherapy is still immature. So that's the first point why you need to have these things. And the second point that I would like to make is there is a slight difference. Now, many people would argue that even after stating this, logistically and financially, it is not possible for many patients, especially in the rural parts of India, to have a proper biopsy and the battery of tests done, because many of these tests have to be borne out of pocket. So the question is, why should you know this? Now, if you look at the EGFR story and the ALK-ROS part of the story, this is again important. In EGFR mutated advanced lung cancer, giving chemotherapy versus TKI is actually detrimental. And there is data from at least one very important trial called IPAS, which clearly showed that if you give standard chemotherapy, and I'm not talking of immunotherapy, because immunotherapy I don't think is a practical option for most of these patients, again, because of finances. So if you give them chemotherapy instead of a EGFR TKI, you are actually doing harm. This is very important to understand. And that is why you probably need to convince the patients to undergo a biopsy and look at EGFR, which is about upwards of 30% to 40% in most of the Indian data that we have. It is different for ALK and ROS. Now, ALK and ROS, Dr. Goswami already told you, is a very minuscule proportion to EGFR. It's less than 10% in most series across the globe. Here, chemotherapy actually works pretty well. So even if you do not give the drug, you are not doing harm. You are doing less good in terms of chemotherapy. And there are guidelines, including probably NHS, which correct me if I'm wrong, Dr. Goswami, that sometimes some of these drugs are also not recommended because you have benefit, substantial benefit with chemotherapy. So ALK and ROS is slightly different. Again, with a targetable TKI, you would extend survival from chemotherapy, but it would be chemotherapy would be less good than TKI. But in EGFR, the story is slightly different. You will not do so good in EGFR TKI directed tumors where a TKI is a must. And just the last quick point, I'm sorry for making it so long, is that in immunotherapy, there is, I think, now quite credible evidence that if there is a targetable driver mutation, and that includes EGFR and ALK and ROS, it is preferable not to use immunotherapy, even if the PD-L1 status is pretty high. Although this is a point of slight debate, but I think there is a lot of evidence to show that if a patient has a targetable driver mutation like EGFR, ALK, or ROS, together with PD-L1 overexpression, it is probably less prudent to use immunotherapy in these patients. Thank you.
Thank you, sir, for the clear insight. There is only one question unanswered. There is asked by Dr. Shubhecha Bushal. Is single fraction for cord compression is practiced? Please, any
Yes,
of
so I
you?
think I actually answered that in my presentation.
Yes, sir.
So currently, I think in the NHS, a lot of centers are using it routinely. I must say that I had not used single fraction for more than maybe a couple of my patients when I was still in Kolkata, but I think there should not be any reason not to use it. We have trial evidence. So I think that actually solves a lot of logistic problems in terms of these patients and how they're handled. And just going back to the point that Abhishek raised about the biopsy and driver mutation. So yeah, I mean, as I say, I mean, it was in my slides as well that when we're talking about PDL1 status, it's really for the EGFR ALK non-mutated population, because if they are mutated, then you would use the targeted therapies. But the one important difference in practice that I see here versus back home is the enormously higher number of EBUS biopsies. So almost 90% of biopsies are via EBUS. So that means that there is more tissue available. And that in a way is actually how it is possible to do all the biomarker studies. Whereas in India, most of the diagnosis is by a percutaneous biopsy, and that doesn't always give us enough tissue. So I think in some ways we are constrained by the lack of interest in our respiratory physician colleagues to actually perform EBUS biopsies, and they kind of treat it like something exotic, whereas it is actually very routine elsewhere in the world.
Thank you, sir. Hope the question is answered. As there is no more questions, I think we can call it a day. Thank you, everyone. Thank you, respected faculties.
Okay, thank you.